Well, good evening, everybody. It is 6 o'clock, and we're going to start. This is our final part of our series on national health insurance. We have over the last few weeks met on a Tuesday evening for an hour with members, and we've discussed various aspects of the National Health Insurance Act, questions around implementation, question around whether it'll actually ever be implemented, and so we've shared views and we've really appreciated the involvement of many who have attended. Those recordings are available. So if you hop onto the profmed.co.za website, you'll be able to pick up on the previous discussions which we have been having. In fact, our first discussion was really around much of the Act, and we had then Esme Prince van den Berg that shared a few views of the framework of the Act. Last week we had Dr. Aslam Dasu also join us and share a few views in terms of the implications on a healthcare provider. And so this is the last in terms of this series, but we've seen a lot of interest. We've had at some stages about 700 people or 700 of our members join and are interested in the National Health Insurance Act and the implementation. So we thought we'd pause after tonight's session and look at having another session in about a month's time. The reasoning for that is probably because by then we'll have a clearer view in terms of the Government of National Unity. We'll have a clearer view of who's running the portfolio of health, and so we can then see and glean any direction in terms of national health. The National Health Insurance Act going forward. So for this evening's conversation, you have me in terms of the conversation, and so I see there are many people that are still joining, but welcome to this evening. We are going to end at 7, and we hopefully will get enough questions in, and many of I can assure you I don't have all the answers, but where we don't have answers, we will share them online, and we'll be sharing that detail with you. So I can't hand over the hard questions to any guests this evening. You are stuck with me for the next hour, but I'm looking forward to the engagements that we can have. So I think one of the things that we pick up, and our medical scheme is all about our members, professionals that obviously whose time is really important, and so we realize that even an hour is a big commitment out of your diaries, but we thank you for that. NHI should never have lost sight of caring for the healthcare consumer, whether you are a member of a medical scheme or whether you a person who relies almost exclusively on the public sector in terms of accessing healthcare. We need to refocus NHI or any universal healthcare system to make sure that we're improving our care that we provide to all South Africans. So some of the things that we have been talking about is the legal framework of NHI. I have shared and maybe we'll just confirm again the constitution and legal challenges that ProfMed is a process or is a partner of in terms of our constitutional challenges to the NHI Act. Specifically around the freedom of access to healthcare, and that's Section 33 of the National Health Insurance Act, which relegates medical schemes to only playing a small part in the future of healthcare. There is a point to be made that both, whether it's a National Health Insurance Act that we reference, healthcare, whether it is provided in a public space or in the private sector, healthcare does need reform, and that we do need to find areas of collaboration to improve healthcare for all. We know that the reforms will impact many providers, and as ProfMed, we have a specific interest in that. We still have around half of our 35,000 families on ProfMed who work in the healthcare industry in some way, shape, or form. And so it does have a direct impact on how providers may need to be structured in a NHI context as well. And then finally, hopefully this evening, I can give you again just a view of where the role of medical schemes is set to go forward. our very clear views in terms of the fact that we'll be around for the next few decades while the health systems and the reforms take place. So I'm going to move on to just NHI in general, and this is just a general statement from a view on NHI. NHI at its core is a medical scheme, but it is a different medical scheme that's managed in a different way and obviously funded almost exclusively from the tax base and the tax collections that take place. So in terms of the NHI Act, and this is in terms of the various parts of the NHI Act, the health consumers will have to register as a user to access the benefits once they have been designed and described. We have heard from many that are unhappy with the fact that the NHI Act has been signed into law, talking about boycotting the NHI, and that is a possibility, but it does, if the Act is implemented in the way it says it is, it does result in you having to fund even your more expensive type of treatment out of pocket, and you cannot use a medical scheme to fund the benefits that are included into the NHI Act. The benefits are still to be designed. There's an advisory committee which is to be appointed within the NHI setup to start designing benefits, and like medical schemes, those benefits are often restricted according to the premiums that you can charge, or in this case, in terms of the NHI fund, these premiums are funded in terms of Chapter 10 of the NHI Act is funded in terms of tax. That could be income, payroll, VAT, and then appropriated properly to the NHI fund. You'll realize in this aspect, it also means that there's a reallocation of the healthcare appropriations from the different provinces back into the NHI fund. And in terms of the real challenges, we can understand that the provinces will have problems in relinquishing what in some cases is up to 30% of their overall appropriations back to a centralized NHI fund. So do expect a lot of noise in that space over the long term. I wish I was a fly on the wall so you could see to what extent that appears in the GNU conversations or the policies that the GNU would adopt going forward. So there are talk in the Act about limited claims processing, because the key way that the NHI fund will engage with providers or those who will provide services is through prearranged, predetermined capitation arrangements within a system where there will be district clinics, hospitals, and a very structured referral process. So you can find that structured referral process in Section 7 of the National Health Insurance Act. It does point towards the fact that as a single funder, the NHI would obviously have the balance of power in determining the reimbursement rates or those capitation fees that would get paid to providers. And so hence the sensitivity around how are providers affected in the long term when you have almost a single purchaser that's going to effectively pay most of your income and in an indirect way will employ you within the NHI system. We have some insights into expense management and procurement processes, but those would really materialize in terms of benefits once the benefits are determined. But there is almost a three-stepped approach of procurement mentioned in the Act. Firstly, from what is called those CUPs, those primary service centres, and then both ambulatory and hospital and specialist services are actually grouped together. So the detail needs to certainly come through a negotiated process, and hopefully will assure people working in the system that the system can actually fund their income. That's probably what Prof Med has raised for the last 10 years in our commentaries on the NHI white and green papers, is the fact that there isn't a particularly well thought out value proposition for the provider fraternity. and that there's a lot more work that needs to be done in terms of making sure providers are brought into the value chain in a very real way and participative way in terms of the NHI space. So the last few items, systems and reporting, there's a serious amount of procurement, lots of noise currently in the background on where to find systems. I guess many of the private healthcare administrators are positioning for those systems as well, but also to make sure that one of the areas that has been raised from the start of NHI, accountability and even the prevention of corruption, that there are systems in place to avoid fraud, waste, and abuse as well. So unfortunately, the structure and the governance side of the NHI still falls dominantly, despite having a so-called independent board, falls dominantly under the auspices and control of the Minister of Health. And so I gather we could call it a hospital pass to see how that Minister of Health takes on the responsibility of implementing NHI going forward. So I think the difference between the two slides, I just put in there, same points on the right-hand side, but the real problem with the way that it's designed is that it removes choice, and there is no competition to then the single funded, single purchaser model. And it's the reason why, as medical schemes, we always believe that our research, and through our research, we've seen that very few countries throughout the world, in fact, we can't find any, have outlawed private healthcare insurance as an alternative to the benefits offered within an NHI or a universal healthcare type of system. And so much of our focus in terms of our constitutional challenges is around the fact that you don't need to remove the rights of the private sector, or the rights of the members of medical schemes, to fulfill the role of universal healthcare going forward. And that's very clearly part of the Constitution, and within the Constitution, Section 36 actually provides for the fact that if you have explored or alternative mechanisms to implement things like universal healthcare, you shouldn't then minimize existing rights of those like medical scheme members in the process. And so it's much of that forms the basis of our constitutional challenges. So I am going to briefly just pause there and reference now some of the realities going forward in terms of the NHI. And I thought this was a really telling slide that I've utilized from our actuaries, who are insight actuaries, and it explains the problems that medical schemes often have, but certainly the dilemma that national health insurance will have as it tries to implement that system. And so firstly, you'll see on the top left-hand side, you might have two treatments that actually address the same condition. The one costs 10,000 Rand, but only has a 60% chance of success. On treatment B, it costs 50,000 Rand, but has an 80% chance of success. And so the dilemma lands, well, which one is the right approach? Well, I guess if you consider who is looking at this, then you'll understand where the answers lie. So if it was, if the treatment was for you as an individual, certainly you're going to choose, or for a child or your spouse, you're going to choose treatment B, probably only if you can afford treatment B. And the question is, what happens if you can't afford treatment B? What do you then do? And so question 2 says, which treatment would your doctor suggest? Well, almost every time the doctor is looking out for the best interests of their patient, they're going to recommend treatment B. So the question 3 comes, well, which treatment do you think the funder is going to actually agree upon? And almost inevitably, the funder picks out the one where the most people can receive treatment. And so if they have a fixed budget, like most medical schemes have, there is a rationing that will take place. And treatment A is obviously the route that many of the funders, or perhaps in the future, the NHI, will look at funding, which does mean that treatment B comes at either additional cost. The problem is, within an NHI context, that you cannot go and get treatment B unless you pay out of your pocket. You can't find it within a medical scheme that would cover that treatment because the condition would be part of the benefits described in the NHI. So it highlights a few key aspects: the dilemma of funding, certainly the issue of rationalization, and the issue of the limited resources spread quite thinly in terms of healthcare budgets in general. I also thought this was a really apt, this is by Study, an apt indication of the NHI bill, which is now an act. It sounds good on paper, and then what's the catch? And ignoring the political context, the big issue and the elephant in the room is certainly the cost of financing and the small taxpayer base that will have to fund this NHI. There's nothing in the NHI which comes free. I think the phrasing in the NHI Act actually talks about that users will not have to pay anything out of pocket, but the NHI makes provision for pre-funded funding in terms of the NHI Act. And so some of the concerns that come through in terms of our own concerns from a ProfMed perspective, well, there's no talk of what the budget is, what can be allocated in terms of money to future NHI. We know for a fact that there is, in terms of annual appropriations in the healthcare budgets, 270 billion rand is spent in the healthcare, the public healthcare budget. It's obviously spent quite poorly. Dr. Dasu, now in our discussion last week, actually shared that only 60% of that budget is spent on services, while there's 108 billion rand of it which is spent on either inefficient administration. Certainly we've seen the Tembisa Hospital, skinny jeans sagas, and other corruption of billions of rands in the healthcare sector across different provinces. And the question is whether it actually does cover those who cannot pay for healthcare. And so the questions need to be asked on how to improve the spend in the public sector. If you do improve the spend, we certainly believe there's about 60 billion rand immediately that could be spent more on the service side of things than just the admin, procurement, and other financing related issues. In the private sector, it's said that there's 250 billion rand spent in the private sector, around 230 billion according to the 2022 Council for Medical Schemes report is the amount spent by medical schemes. So there is a difference, and many people still purchase private healthcare cover out of their pockets because they fail to either get access to healthcare in the public sector, or they don't want to face the queues in the public sector. So what we have to do is take that full, or the idea of NHI is to take that full money and spend it at a scaled procurement space, and that's the validation for a single purchaser-based model. We believe that all that you have to do is make sure that you can coordinate centers of excellence in other spaces where the correlation of services still accomplishes the purposes of universal healthcare coverage, but it's done in a far more coordinated fashion, and you can actually achieve better outcomes than the NHI Act. The other concerns that we had were the point that during the last 7 years, there was an effort to launch NHI pilot sites. I think many of the practitioners, if you are in some of the more rural districts and so forth, you may have been aware of the NHI pilot sites that were launched. In fact, more than 20 billion rand has been spent over a similar period on trying to see if those pilot sites would work. Well, the report that eventually came out was a little cagey and drafted with a different heading on strengthening the healthcare sector. But those pilot sites, all of them failed dismally, and for one major reason, and that was because there was no buy-in from the healthcare providers themselves. So they didn't sign sufficient healthcare providers into those pilot sites, and couldn't get the cooperation in terms of those districts. And so there was a major failure in terms of those pilot sites. in the question and answer session to the healthcare minister about the pilot site's failures, the answer was that we at least got to learn what does not work. I gather if you're doing a pilot site, you want to actually have a few things that you can say work and use that as a basis to launch national health insurance districts. So number 3 is just, the point is that unlike other universal healthcare systems out there, our reform in the NHI Act infringes on the freedoms of choice and effectively outlaws the private sector to compete with the benefits offered within the NHI. Now, we believe that in the long term, and certainly not in terms of the timelines provided in the NHI Act, which seems to think that in the next 8 years, the NHI would be implemented. We believe the biggest restriction on including benefits, the benefit design aspect in NHI, is going to be the available tax and funding requirements for those benefits. And the idea of annexing medical scheme premiums or using premiums to do this can only be achieved by increasing in the tax base. Now, we have heard from the Minister of Finance, and they are key in terms of the rollout of universal health care or national health insurance. We've heard very clear indications from the DG there that there is no funding expected for NHI over the coming years due to other priorities such as the basic income grant. And so those policies are set to overtake any allocation of taxes to the NHI, which means that very few benefits will be provided within the NHI space. And in terms of even the much disputed Section 33 of the NHI Act, means that medical schemes can provide whatever NHI cannot afford to actually fund. And so in the long term, the structure of the Act opens this door for medical schemes to actually provide comprehensive, similar benefits to what is currently provided for the long term and for the next few decades. What will change that is if we grow the economy. The answer is if we grow the economy and the tax base increases and there is more funds to allocate to benefits in the NHI, then we'll see that change, but we don't expect that to happen anytime soon. And certainly that gives us some level of assurances that there's no real impact into the medical scheme space for the long term. So number 4 is also an important point, is to say that we have to move past the political promises, which I think the electorate is going to hold those politicians to. And so we have to do something where we reform healthcare in a more pragmatic and practical way to actually give more benefits to healthcare consumers, whether paid for in a medical scheme space or whether it is properly managed within a public sector, is something that has to be coordinated correctly. So national health insurance and the Act mustn't be seen as the only way to achieve improved healthcare in South Africa. And so I've gone into a space, and some of the questions over the last few weeks has been specifically around the reforms. Well, if it's not the NHI Act, then what will work? Well, these answers have actually been around for some time. And so the first point that I wanted to make here is to say that when we consider the public sector services, if we look back 10 or 15 years ago, in fact, 20% of the public sector health services were still funded by medical schemes. So members are entitled even now to access centers of excellence or spaces in the public sector that provide good quality services. And there are a few of them. We just need to try and grow the amount of those there. And so we see 15 years ago that was sitting at 20%. In fact, in the last few years, because of the deteriorating public sector, that sits on about 5%. But it does point towards the opportunity that there is, if the public sector and the public facilities are upgraded, managed and maintained in the right amount or in the right way, it can attract private healthcare investment from both the paying public, and then from medical schemes as well. And so that could introduce as much as 40 to 60 billion rand back into the public sector purse, which means that you can, in fact, expand the level of access and services to those most vulnerable, and in that way extend your very goals, the very objectives of NHI. You can actually achieve that in a far more reasonable way. More than 10 years ago, or just on 10 years ago, the Competition Commissioner started what is termed the Health Market Inquiry. And so these are reforms that took 5 years to actually put together. There were a number of consultations, data submitted from medical schemes, administrators, hospital groups, and other. And the Health Market Inquiry then unpacked a few key reforms that should be implemented in order to promote and improve affordability within the medical scheme space. And as you get the medical scheme space more affordable, obviously there are more people that will join the medical schemes, thereby removing the pressure on that 270 billion rand in the public sector to then only cover those who need healthcare, those most vulnerable in the public sector then. So the reforms under the Health Market Inquiry, I'm not going to go through the details there. You can see things like mandatory cover for formerly employed, the risk equalization mechanism, which means that schemes don't compete for better risk or younger people in the market, but actually compete on the service offerings and the benefits that they include. And in that way, what you would do is create affordabilities anywhere between 20 and 30% of medical schemes could be more affordable if we attract the people who are paying for private healthcare out of their pocket but don't belong to medical schemes. It will also attract those who can't afford into that space, allowing the 27 billion rand to actually be spread over fewer indigent and vulnerable individuals. Another way to do this would be to actually implement the low-cost benefit option space with the relevant PMB reviews and exemptions currently provided to health insurance products in the market, that those will disappear and low-cost benefit options will be part of medical schemes in the future. Also, there's an opportunity to actually incentivize medical scheme coverage. The fact that in the last year, the budget speech, medical scheme rebates remained exactly the same is a problem, because it creates less affordability for people to join medical schemes and works the reverse of my previous point. It means that more start relying and putting pressure on the public sector facilities. And so you have to stretch the 27 billion over more people. And so we actually do need to incentivize, like many other countries, incentivize individuals to pay for their own healthcare, and thereby they can more effectively utilize the remaining tax or fiscal spend. The last point is one that we always raise as ProfMed. We believe that the supply of healthcare practitioners, or training more healthcare practitioners into the system, is something that works. It can, in the long run, reduce the cost of healthcare in general. It's just an easy supply and demand sum that comes into play. And there is space. Medical schemes currently sit on about 60 or 70 billion rand in reserves. There could be a real smart mechanism put in place to use those reserves to finance additional nursing colleges, training schools, and so forth, provided that the government is willing to open up the training and allow private investment into that space. So we continuously make this point that the success of any healthcare system still depends on the critical skills and our abilities to retain those critical skills and build more of those skills in the market space. So this slide I've shared previously, and these are the points in terms of if anybody asked what is ProfMed's view in terms of the NHI. Well, we've always supported the fact that universal healthcare is an objective. We want everybody in South Africa, regardless of their financial position, to gain access to good quality healthcare. And so that is the WHO definition of universal healthcare. Prof Meg does disagree that the NHI Act is the way to do that, and you can actually achieve that through different means. And so that means that we will advocate for the rights of medical scheme members through either legal processes, constitutional challenges, or where possible, if there is opportunity to redirect or reform the NHI Act in any way, we would be first in the queue to be part of that process and to try and influence a different direction to the NHI Act. So the other part, promote and preserve the role of health providers. I spoke to that a little bit earlier. But also what we do need to make sure is that those reforms in the health market inquiry are implemented, because that will ensure more sustainable private healthcare into the future. And that's something we do look forward to. So that's where I'm going to pause. And I know I've been speaking for a long time, but I'm going to pause and provide the rest of the time to everybody attending, and we can answer some questions. And I don't mind if there are questions that have previously been shared, but I'm going to ask our IT administrator, Mpho, who has sat every Tuesday night here and helped us. Thank you very much, Mpho. But if you raise your hand, she will unmute you and allow you to pose your question. Alternatively, if you are struggling, then please won't you pop it into the question or into the chat section, and I'll pick up the questions there then. So I'm going to hope if we can start, Mpho, if you can allow Bryant or Brian T to pose the question, and let's see if we can answer a few of these. So Brian, see if you can unmute your own mic. Yeah, the IT guys will do that for you if your hand is raised.
Mic is enabled. He just needs to unmute.
If you want to try again, Brian. Seems like that's the only question currently going. Please also type in the chat, Brian, if you'd like to. Please do that. I'm going to refer to one of the questions that we received during the week, and so we do have an email address open. And so one of the questions during the week was an existing member who has a chronic condition and uses a specific specialist in Pretoria to access her treatment, lives in a different part of the country, but has chosen to use a specialist for the condition in Pretoria. And the question is, how would that be affected by NHI? The answer is always not as simple, but the point is, if you are to access both what is now considered a public provider or a private sector provider, a specialist, those providers would have to be registered as a provider on the NHI. It is unlikely that you would get access to them, because in terms of Section 7, what you would find is very much the referral processes that currently exist in the public sector healthcare system are the same referral processes that you would have to go through to reach a space where you get to a specialist for your condition. So effectively, you'd have to first register with your primary healthcare specialist if they are accredited by the NHI. That GP or primary healthcare person will then refer you to an appropriate specialist or hospital setting. Usually, in the current terminology, it's called the district hospitals and so forth. There are, if you're unhappy with that, you'd have to go through a process of appealing to get to a different specialist to treat you. And so you'll find that the process written into the Act still looks rather cumbersome, and we're hoping that some of the regulations that come from that will enable better, certainly an easier way of that working. But at the moment, it does rely almost exclusively on that GP referral process to a specialist within your current district, and you'll understand that because if the NHI is going to fund healthcare cover based on specific risk indicators, then it is important. Sorry, I've got a moth flying here. Then it is quite important that that you use those capitation arrangements. So both the CUPs, the primary healthcare CUPs, and the districts are going to have to cooperate together in terms of getting that right. So I'm going to just stop there and see again if we can. Brian still says he's unable to mute. Apologies, Brian. I'm not sure why that's so difficult, but please put into chat. We've noted that your comment in the chat. Maybe you can pose your question under the chat section. So please, if you can, just raise your hand, and then our administrator will unmute you, and we'll try and answer your question as well. Great. This is a good thing from Brian. It says, what percentage of the 250 private sector is spent on services? So as I mentioned earlier, the 250 billion rand is a combination of the 230 billion rand spent by medical schemes, and then the 20 billion people spending out of their pocket and accessing private healthcare. So if we consider what is in the medical scheme space, on average, the administration services, which include, if a medical scheme, mostly in the open scheme market, has to pay brokers or other marketing activities, administration including claims processing, management of membership and managed care type of funds, that amounts to 10% in the medical scheme space, and those are annually disclosed and reported on in the Council for Medical Schemes annual report. So please, if you want to go check those reports out, please go to the Council for Medical Schemes websites. You can download all the reports annually. They usually are a year behind. So in the next probably 3 months, we'll only receive the 2023 annual financial statements and report from the council. So I hope that answers the question. Dr. Seethrahim is struggling to connect, but we have another hand. Ilana Erasmus, Mpo, if you could open that mic for us, please.
Yes, hi Craig, can you hear me?
I can. Thank you.
Craig, I'm sorry if this was maybe a question in the previous sessions. I wasn't able to attend them, but I recently attended a seminar where they had a panel discussion on the NHI, and one comment that was made in the panel discussion was that maternity benefits will no longer be covered by medical schemes once the NHI has been signed into law. So it's like treated differently than the other benefits, because the other benefits will only be excluded from medical aid cover once the NHI is fully implemented. But regarding maternity benefits, he said it's like when the NHI has been signed into law. Obviously, it has been signed now, and I'm just curious to know what is the development there. Will it still be covered, or do you have any insight regarding that?
Yeah, so I understand exactly where that comes from. It's the one benefit that is already mentioned in the NHI Act. So absolutely right that it doesn't seem to form part of this benefit design process. But none of the acts can be implemented unless there are funds available. So there is no NHI fund as yet. It's yet to be established. There's no board, there's no CEO, and there's no benefits advisory committee, and more so, there's no taxes allocated or redirected to that space. Part of the agenda, and we've had similar conversations at the Health Funders Association. Part of the agenda was always that the first thing that the health department wanted to address in NHI was the child and mother mortality rates during the birth process, the pregnancy and birth process. So that was why it was put in, but it actually doesn't make sense. And unless you've got the other mechanisms in place, you cannot fund anything to do with maternity at the moment. So that means that it's still left over to the medical schemes to fund as is. Now, the question is, are we ever going to get to the stage, or the next question, are we ever going to get to the stage where NHI has an impact even for things like, and first off, like maternity? Well, I would suspect that that may be the first benefit included, but there would be aspects of maternity that has to be excluded and will be subject to a number of cases. Our constitutional lawyers, so these are the guys that are driving our challenges, have both indicated that the process of the NHI Act being signed into law doesn't mean that now we just go in and implement. There's this strange additional step where, in fact, the parts of the NHI Act need to be proclaimed, so that the Minister of Health will actually do. And for many who are GPs will realize that the National Health Act that was brought in the early 2000s, there was this issue of a certificate of need, which in fact was only, I think there was an effort to implement or proclaim that part of the Act in the last 3 years. So it's taken almost 20 years to get to proclaiming that part of the the National Health Act, not the NHI Act, it's the National Health Act. So there's this strange step-by-step process where even though the Act is signed, parts of the Act need to then be proclaimed. The Minister of Health and the Deputy DG of Health has also indicated that those things need to go through a regulatory process, or they will publish regulations for implementation, which then means that there's 90 days to consult and engage again and comment on that. So I don't see the maternity issues actually having any real effect at the moment at all. And I think any efforts to implement that would be subject to legal challenge from the industry as well. I hope that answers your question comprehensively, Ilana.
Yeah, definitely. Thank you.
All right. I've got another question from Sine, just a follow-up question that was asked on the chronic condition. What would the role then be of having a medical aid? Would it even help to have a medical aid if the NHI is in full effect? So the very interesting reading relating to Section 33 of the National Health Insurance Act does say that the role of the medical scheme only changes once the NHI has been fully implemented. So the issue of fully implemented is not very clearly defined, and whether the health minister, I guess the argument from us medical schemes is whether the health minister can just all of a sudden proclaim that NHI is fully implemented even when it's not, is the question that we're asking. Because there should be very clear milestones of what implementation means and what fully implemented means. And so until such time as fully implemented, medical schemes roles will not change to the complementary benefits that or statement that's made in terms of the NHI Act. So in terms of the chronic condition, you would keep your medical scheme until you hear anything that says anything close to NHI being fully implemented. Nothing will change for that individual. I think the point I will continuously make here is that we have an act at the moment there are no regulations. I have serious doubts whether NHI will even be implemented. And so I often speak from the basis of if it gets implemented in the long run. But it is, in terms of the Act, it is envisaged that a comprehensive set of benefits will be provided within NHI, and that those benefits, if stated within NHI, medical schemes cannot provide the same benefits. And hence where all the legal challenges start to emerge then. So I'm going to hopefully, Sune, provided you with that answer. I'm happy to deal with any follow-up questions that you might have. Dr. Seetharam, has NHI taken into account medico-legal claims that will take a sizable chunk of the NHI pool of funds? Yeah, I can understand where that question comes from, Doctor. I see it's estimated that there's outstanding legal medical claims to the value of 120 billion rand sitting, waiting for the public sector to in some way be paid or validated through the legal processes. I don't think there's been any updating of the budget required for the NHI. So as we get a benefits advisory committee, and hopefully there'll be a few actuaries that'll come on board, we will then understand how much those benefits cost. And so, I mean, there are suggestions that the cost of NHI would be anything between 400 billion to 800 billion rand per year. And so it really is largely depending, and the big depending factor is on how much tax appropriations you can actually get. And so I don't believe that it's a realistic consideration to think that the NHI is all of a sudden just going to adopt and take on the liabilities, the medico-legal liabilities, and to what extent arrangements between the NHI and if they contract with you as a doctor, if the fees would be sufficient to actually cover you in terms of your own indemnity. I have my doubts that they're going to want to assume that as well. I think it's going to be the responsibility of the doctors themselves. Follow-up question also from Dr. Seetharam. If all of us are employed by government, then we will not need indemnity cover. Yeah, providing that the government would still take out the cover, I guess. Even in the public sector where doctors are employed, there's no doubt that there should be some type of indemnity cover needed if you consider the amount of outstanding claims in that space. I don't see any other questions coming through. Just a reminder that what we are planning to do at ProfMed is in about a month's time, we will schedule another webinar. We think there's certainly a lot of interest coming in from our members just to pose these questions. We don't mind if we need to pull in another industry expert to answer them, or if we have the abilities to answer the questions. I gather we have a very good team of boards of trustees on ProfMeds and our association with the Health Funders Association, which actually means that we've lived the design, the planning, the white and green papers of NHI for the last almost 2 decades. And so we have some of the answers, but we'll have to watch the GNU very carefully in terms of its approach to perhaps a differing and hopefully a differing healthcare policy that will need to be implemented. Another question from Shelley. Thank you for the question, Shelley. It says, I'm understanding correctly that NHI has no benefits assigned as of yet as health coverage. There's no set of benefits with budget. So right now we don't even know what the NHI will cover or how the national funding will be allocated per person, and it will take perhaps years before this is sorted out, if it gets sorted out. Absolutely agree with you. I think it's a big if. You can see how complex implementing something like this becomes, and I think we hope for some pragmatism to actually come through. So I agree with almost all your points there, Shelley. I don't think you need to worry as yet. There's lots of water to run under the bridge, whether it's legal challenges, whether it's centralizing the provincial healthcare budgets into an NHI. These are going to get stuck in significant legal challenges, while in the interim, the funding question and the ability to actually raise taxes is non-existent in terms of even the views of Dr. Mark Bletcher, who is the DG at Treasury, who has over the last probably 2 months actually shared very clear views that there just isn't money ready for an NHI fund. You're so welcome to put your hands up, and we'll unmute you and hear your questions if you have them. So please, welcome to do that. Otherwise, I'll keep on looking at the chats. There's a chat from David Banford. David, do you want to? We'll unmute you and you can pose your question.
Thank you, Craig. I'm not sure if you can hear me or not.
Yes, I can.
Unfortunately, I wasn't able to access all of the meeting, but I have a question. I'm a non-resident visitor, but a very frequent visitor to South Africa. I've been happily covered by ProfMed for many, many years, more than 10 years. NHI ever went ahead, what would the provision be for overseas visitors, and would overseas visitors be allowed to continue on private medical cover?
Yeah, David, I wish I had a clearer answer for you. Being registered as a NHI user means that you would have to access benefits within that system. If you aren't willing to do that, you'd have to pay out of your pocket. And unlike the NHS or some of the other health systems in the rest of the world, the Section 33 of the Act says that you cannot use a medical scheme to cover those same benefits. So it's unlikely that you can actually use a scheme like ProfMed to cover the same benefits. But again, we're in the space, and our views are that NHI is a big if and not even a when it's implemented. We're going to see lots of political noise about establishing the fund, but getting to the space where you actually have benefits, we think the economic position of South Africa will halt the amount of benefits that NHI is set to offer. And perhaps in a perfect world, we'll see the NHI Act either being scrapped or changed to something that is more realistic.
Right. But as currently mooted, as a ProfMed member, I would not be able to take any benefits from ProfMed, so I would not be covered in this country.
Correct. That is right. Then, if it's mooted the way that the Act is written, you're then correct. And the complementary benefits that medical schemes will be relegated to offer is probably going to sit in the dental optometry spaces, a very small top-up insurance type of cover.
Right. Well, thank you, Craig.
So thanks, David. I'm not seeing any other questions in the chat. No other hands that have gone up. I'm going to just thank everybody for attending. We appreciate you being members of ProfMed. We're here to cater for professionals. We are going to be advocating for a reform of the NHI Act, a change to enable us to continue as medical schemes, and we're quite confident that that will happen going forward. So please don't think anything is going to change in the near future. And we'll keep you informed of all the conversations, discussions, the legal outcomes and implications. And so trust us with that. And thank you for your time this evening. We'll bid you farewell. Thank you.